Welcome everyone and good evening. Welcome to the today's webinar, Topical Issues in Pain Management. For those of you who don't know me, my name is Penny Gaskell. I'm GP Liaison at Eastern Health and Clinical Director of some of the ambulatory care services, including our amazing ambulatory pain management service. I'd like to introduce our co-hosts. So we have Carlos Bello, who's the team leader. You might want to wave, Carlos, the team leader of the ambulatory pain service at Eastern Health, who's been wonderful enough to set this up with very short notice. And we also have Christine Bellamy, who might give us a wave. And Christine is the Quality Use of Medicines lead at the Eastern Melbourne PHN, and she's been also wonderful to work with. So this webinar is part of a series of webinars called the Pain Management Clinicians, and they're designed to support doctors and allied health practitioners to develop knowledge and skills in the management of complex pain presentations. And we're recording this webinar and we'll post them for future reference. And I think we could possibly, Carlos, in the chat, put up the link rather than me read it out for those of you who are interested. And some of the topics covered today include complex regional pain syndrome, chronic pelvic pain, borderline personalities and others. And I believe there's more to come. So they're obviously very common issues, particularly in the primary care setting. So without further ado, I'd like to introduce our wonderful presenter who's sitting there very patiently in front of the very nice green screen, Ferghal Armstrong. Now, Ferghal is the founder and principal GP of Blackfish Medical Clinic in Kuwirup, and he has special interests in chronic disease management, addiction medicine, dermatology, and skin cancer diagnosis. Ferghal is a FRAC GP, or a fellow of the Australian College of GPs, and he's also a specialist in addiction medicine. And he's presented on Safe Script and Turning Point webinars as well. And he's the co-founder of Meducate, which is an online portal which provides CME training packages for GPs and allied health. And maybe, Ferghal, at the end you could give us some information on that if you like. So without further ado, I'll hand over to Ferghal. And as I said, pop any questions in the chat and enjoy the presentation.
All right, so Penny, thanks for that introduction. I'm going to be talking tonight about the role of GPs in the management of chronic pain. So the learning objectives for tonight are as follows. So fundamentally, we need to understand the difference between acute and chronic pain. They're two very different diseases. And we need to understand the medical legal framework, which has changed recently. And I want to introduce tonight the concept of the 6 pillars of lifestyle medicine as a framework for thinking about all of the stuff that I, as a GP, certainly don't really factor into my consultations, at least not till recently. And then finally, I want to talk about the socio-psycho-biomedical model of care and how really that's the only way of managing people with chronic pain, especially chronic non-cancer pain. So first of all, I want to talk about a case. This is a real life case. This is one of my patients in my general practice clinic that I've had to manage in the last year or so. So she's a 53-year-old lady who came to me because her previous GP was retiring, and the subtext was that no one else in the surgery wanted to take her on. So she came over to my clinic in distress. She's got a past medical history of fibromyalgia, chronic back pain, depression. She's had a previous overdose of pills. She smokes. She's got reflux, stomach ulcers. She's got a BMI of 32. She's overweight. She's got obstructive sleep apnea syndrome and uses a CPAP machine. And she first of all came to me on Targen 60 milligrams twice a day, plus a bucket load of short-acting PRNs, including Endone, Panadeine Forte, and Tramadol. And I calculated her OMED to vary between 200 to 220 milligrams a day. And of that entire cocktail, it was actually the Endone, the 5 to 10 milligrams of Endone, that actually gave her the most benefit and got her through her pain flares. She was also on duloxetine, diazepam twice a day, and omeprazole for her reflux. So, you know, quite interesting polypharmacy going on there. So I asked her, what did she want from me? What help did she want from me? And she said she wanted help with chronic pain and she needed a new prescriber for their medication. So as we all do now, I looked at Safe Script, and it's no surprise that there were a bucket load of red alerts all over her record. So there were red alerts for high OMEDs and polypharmacy. So I've given you the synopsis of the case as I first met this lady. And I want you to think, as we're going through this presentation, what are the things that concern you about this case? And then we'll try and wrap it up at the end. So let's go back to the learning objectives. So what's the difference between acute and chronic pain? So firstly, all pain has an emotional component, and all pain has to be believed. You know, you can't say, oh, they're not in pain. Right? Pain is pain. Pain is what the patient describes. And all pain, even acute pain, has an emotional component. Acute pain, however, there are various definitions which include, time points, so it's less than 3 months. It's associated with tissue damage, as a result of which it creates noxious transmission. And there's a survival benefit. There's an adaptive benefit to it. So, if you put your hand in the fire, you get acute pain, you take your hand out of the fire. It allows you to survive. People who don't have acute pain end up with serious medical problems. Chronic pain, on the other hand, lasts for more than 3 months. Chronic pain persists despite maximal tissue healing. So you're as good as you're going to get. There's no more time to, there's no point in waiting for further benefit from tissue healing. And chronic pain is maladaptive, so it persists beyond use. And this is going to be the main issue that we all find challenging about pain management. Now, this slide, I want to show you how acute pain or inflammation causes a pain that flares up and then gets better as time goes on. So as healing progresses, you'll see the dark red line decreases. So acute pain associated with noxious transmission, associated with tissue damage, it eases off. However, there are some people for whom this pain persists. And there's a wavy line on this graph which demonstrates the vagaries of the pain experience. As people go through their daily lives, their pain gets worse, their pain gets better. They're buffeted by the winds of life, basically. Adversity makes their pain worse. And we know that medication really doesn't work very well in this situation. Even though we see opioids as the mainstay of treatment for pain, we know that in chronic pain, this maladaptive pain, we know that opioids don't work well. We know that opioids are associated with dose escalation over time, and that in and of itself is associated with various issues, including opioid-induced hyperalgesia. We also know that actually anything but medication works better. So the pain team is the most evidence-based intervention that you can get to help with this kind of chronic non-cancer pain. So this space between the top line, the top wavy line, and the red line, that is the space where angels fear to tread. That is a space which we, as clinicians involved in the management of chronic pain, that is the space that we have to occupy. And the good thing is that we will never be superseded by artificial intelligence if we live and occupy this space, because one of the key factors about managing patients in this kind of distress is human empathy. And as far as I'm aware, artificial intelligence can never create human empathy. So what are the risk factors for developing this kind of chronic pain? Well, we know there are genetic risk factors, including the catecholomethyltransferase gene. Polymorphisms of that gene is associated with flares of or persistent pain, especially in fibromyalgia. And we know that neuropeptide S receptor polymorphisms are also associated with the worsening experience of acute and chronic pain. From a phenotypical point of view, we can see that we all know that fibromyalgia is associated with chronic pain and also a reduced or reduction in the diffuse noxious inhibitory control, that ability to kind of stop pain getting through to the brain. Trauma, adverse childhood experiences, any kind of trauma in the past history will increase the risk of suffering acute pain. And also, as a result of trauma, we have to bear in mind catastrophizing. We know that catastrophizing increases the risk of prescription opioid use disorder and prescription opioid misuse in patients in chronic pain, especially if they're using high-dose opioids. So that is a factor that has to be identified and treated. We also know that mental health disorders, especially the trauma-related disorders, they increase the experience of pain and increase the risks of chronic pain. So there are genotypic and there are phenotypic risk factors that we know about that will perpetuate or at least increase the risk of chronic pain. So a little bit more on catastrophization. So think of it as ruminating about pain, the magnification of pain, and hopelessness. So rumination, I can't think of anything but the pain. The pain is 10 out of 10. It's 11, 12 out of 10. And the pain's never going away and I'm never going to be able to cope. Hopelessness. Hopelessness is a very difficult harbinger symptom, both of catastrophization and also of depression. And hopelessness really does need to be identified and managed. And we know that catastrophization increases the risk of prescription opioid misuse. It also impedes the response to physical therapy. So, why are you making me exercise when my pain is so awful? It's 11, 12 out of 10, and you're expecting me to engage with physio. I just can't. So catastrophizing needs to be identified and needs to be addressed to open the gateway to a good multidisciplinary team approach to pain management. So let's talk now about the medical legal framework. So SafeScript is now mandatory for all prescribers in the community. It's not yet mandatory in hospitals, I don't think. But SafeScript gives us an indication of risk, and it gives us red alerts. And there's a red alert if SafeScript thinks that the amount of opioids that is being prescribed for a patient exceeds 100 milligrams of OMED, oral morphine equivalent dose. And there's a red flag there because we know that OMED more than 100 is associated with up to an 11 times risk of death, higher than in patients who are less than 20 of OMED. We know that polypharmacy increases the risk of death. And what do I mean by that? So the combination of benzodiazepines and long-acting opioids. So just remember this, why is there such a risk of death? So just remember that opioids will knock off your Opioids will knock off your hypercarbic respiratory drive. So when you stop breathing, you retain CO2, and that usually stimulates you to breathe again. Opioids will blunt that. Benzos will knock off your hypoxic drive. So when you're knocked off on your hypercarbic drive, the only thing that's keeping you alive, that's keeping you breathing, is hypoxia, that hypoxic drive. Think of these CO2 retainers in COPD. Benzos will knock that off. So it's the combination of opioids and benzos which will really prove lethal. And this is one of the reasons why SafeScript identifies that risk, or that combination of prescribing as such a high risk. We also know that multiple prescribers, multiple dispensers also causes incoordination of care, which also then contributes to mortality risk. So these alerts on SafeScript have to be acknowledged. They're not developed without, willy-nilly. They're trying to tell you something. This patient in front of you with a red alert has got an elevated risk of death. And really it behooves all prescribers to actually take note of this and to do something about it. The second key change in the medical legal context is the change in the PBS restrictions for opioids. And one of the things that people find most troublesome is this requirement for the 12-month review. And someone who's on long-term opioids, the PBS requires you to do a 12-month review by another medical practitioner. And for further opioid prescribing, you need to supply the reviewer's name and the date of that review. I think it's really important to emphasize in the context of tonight's discussion that that person doing the second review does not have to be a pain specialist. You do not have to refer your patient to the Eastern Health Subacute Pain Clinic or the ODPAC Clinic just to get a 12-month review. That reviewer can be anyone else in your practice, or it can be a doctor and a neighbor in practice. It can be a friend of yours. It does not have to be a pain specialist. You do not have to refer your patients to a chronic pain specialist. I like to use the analogy in this situation of the management of type 2 diabetes. GPs own the management of diabetes. It's very rare for a patient with type 2 diabetes to be referred to see a diabetologist or a diabetes specialist unless they're in that small cohort of patients that are really complex and troublesome. And I think that the management of chronic non-cancer pain should be seen in a similar vein, where the vast majority of patients are managed within their community. They are not referred. We'll talk about how we can actually achieve that as the talk goes on. So, the 6 pillars of lifestyle medicine. They are the feet, the finger, the fork, sleep, stress management, and socialization. This is just a way I have of thinking about all of the lifestyle factors that can impact upon health that I feel need to be broached in the management of any patient who has a complex chronic disease. So it's not just limited to patients with chronic pain, but I'm going to put a pain bent on this. So let's look at these. The feet, first of all. Motion is lotion. Activity keeps you moving. Activity reduces chronic pain. Activity modulates the pain experience. And we know that people who exercise more actually have greater diffuse noxious inhibitory control. They can suppress pain signals. And we know that really good going vigorous leisure activity over 12 months will reduce the pain experience. And one of the things I need to emphasize to my patients all the time is when I tell people to move more, when I'm going to refer them to physio, and they say, physio was useless because all he did was tell me what to do. He didn't touch me at all. He didn't rub me at all. And I have to emphasize to patients, look, a physiotherapist these days is not going to rub your back better. A physiotherapist these days is your coach, your sports coach. He's going to teach you how to get better yourself. He's going to make you do these exercises. He's going to show you how to do these exercises safely so you don't do harm. He's going to be your coach. He's not going to rub your back better. It's a patient's activity, their motion, their lotion that's going to get them better. And it's also going to reduce their experience of chronic pain. We know that activity improves various pain syndromes. There's very good evidence from Cochrane reviews that exercise, land-based exercise, so weight-bearing exercises, improves hip and knee osteoarthritis pain. And the most recent guidance for the management of mechanical back pain, simple back pain, includes antidepressants, NSAIDs, and exercise, as well as psychology. Exercise is key. And I note that in there's a role for duloxetine, and I'm actually beginning to think that duloxetine really should be a first-line drug for the management of osteoarthritis pain. And we can talk about that, and hopefully in the question and answers we can have some toing and froing on that issue. That's the feet. Now we come to the fork. And by the fork, I mean diet and weight management. We know that central obesity causes pain. Not only does it cause pain because of mechanical stress, but it also causes pain. Central obesity causes pain by stimulating a pro-inflammatory state. Now, we know that, or history tells us rather, that about 2,000 years ago, a bloke called Aurelius Celsus described a condition which he called inflammation, and he described it at 4 key components: rubor, dolor, calor, turgor. Redness, pain, swelling, and rubor, dolor, heat. And as time went on and we understood what inflammation really meant, we also added in a Latin term either torpor or functionis laesia, which means loss of function. And that's what we understand as typical inflammation. But then in 1993, Hotamas Sligel, he was a Turkish physician, he developed the concept of meta-inflammation. A meta-inflammation is a dysregulated, maladaptive, prolonged inflammation that perpetuates disease rather than treats acute disease. And it is this meta-inflammatory chronic inflammation state, this pro-inflammatory state, that causes pain and is associated with obesity. So we're now realizing that obesity actually is not just a mechanical issue, it's a metabolic issue, it's an inflammatory issue. Now we come to the fingers. So what do we mean by fingers? I use the fingers to denote the concept of smoking and also other addictions that need to be treated. And that's where I'm particularly interested, because I'm also an addiction medicine specialist. So, and the case that I'm going to that I've already introduced, there's a significant component of addiction in that case. But we know that smoking worsens all of those chronic pain problems. So it worsens overall the experience of chronic pain and increases the severity and incidence of rheumatoid arthritis. Smoking actually triggers rheumatoid. We know that smoking increases the experience of pain in osteoarthritis, generalized headache, TMJ pain, fibromyalgia. People who've got trauma develop fibro and anxiety, and what do to relieve their anxiety? They smoke, but that just sets off the perpetual vicious cycle of smoking causing pain, making the fibro worse, making the mood worse, causing pain again. Dyspepsia, dysmenorrhea, pelvic pain in pregnancy. All of these conditions are worsened. The pain experience associated with these conditions is worsened with smoking. You've simply got to get your patients off the fags. And we come to sleep. We know that insomnia worsens the experience of pain. And we know that there's a bidirectional relationship between chronic pain and insomnia. And we know that insomnia or the lack of sleep impacts upon cognitive function, resilience, the ability to cope, creates mood disorders. It's a consequence of mood disorders, and mood disorders also intertwined closely with chronic pain. It is both a harbinger and also a cause of chronic pain. And stress, well, we all know that stress makes pain worse. Stress sensitizes the brain to pain. Stress exacerbates neuropathic pain, and stress worsens back pain. These are just a few examples of the complex interrelationship between stress and the experience of pain. We all understand stress. The key thing here is to understand that as part of a chronic pain management service, you have to address stress management, and any decent pain management service will have psychologists, occupational therapists, physiotherapists, who are all focused on stress management. And bear in mind, stress management is not just the preserve of the psychologist. Stress management should be part of all of our interventions. We should all be thinking of stress management when we're dealing with patients with chronic pain. It's not something that we can just abrogate or rather abdicate to the psychologists. We all need to do it. We all need to help our patients manage a reduction in stress. And loneliness, socialization. Loneliness worsens chronic pain. It stops us from enjoying life. Loneliness causes depression. Loneliness causes suicidal ideation. Loneliness worsens substance use disorder. Loneliness increases the amount of substances that are used, especially in times of COVID. The most recent paper from McDonough came out recently, and he very effectively demonstrated how the experience and perception of being lonely actually increased the risk of substance use. And before I go on, I just want to emphasize there's other evidence to suggest that loneliness actually increases mortality. It is a big contributor to cardiovascular disease, as is hypertension or central obesity. It has to be identified. It has to be treated. So, bearing in mind, those are the 6 pillars of lifestyle medicine that I think we all should be owning, that we should all be using or conceptualizing when we approach our patients. So what is the approach that we should be taking for patients with this maladaptive chronic pain syndrome that is not helping them anymore? Remember, this is not acute pain. Acute pain needs opioids. This is chronic pain that doesn't respond to opioids. So what should we be doing? The answer is we should be using the socio-psycho-biomedical model of care. And I say it in that order. When I grew up, when I was training, it was always the biomedical model and then the biopsychomedical model of care. It's changed now, and I think it's appropriately changed because the model is trying to emphasize the fact that it's the social relationships, the psychological issues, the biomechanical issues that are more important than the medical input. And I've said it before, and I'll say it again. I view the role of doctors in a chronic multidisciplinary pain team as less significant than every other member of that team. But we can argue on that as well. So let's look at the social first. Social prescribing. I tell my patients who have experienced addiction, depression, or chronic pain, they need to get out more, they need to socialize. And this concept has been with us even before COVID, this concept of social prescribing. It's a mechanism for linking patients in with non-medical services and non-medical supports within the community. So it can be referrals for arts, crafts, physical exercise, anything that gets a patient out and about that is recommended by a doctor can be regarded as a form of social prescribing. The success of social prescribing there's a lack of evidence of success in randomized control trials. And I think we're getting better at actually working out what makes social prescribing more effective. And one of the key things is there has to be an effective link worker. Without that link worker coordinating services with patients and patients with services, and without that link worker facilitating and enabling service engagement, you don't get the benefits of social prescribing. But that doesn't mean that we should just stop worrying about it if we don't have a link worker. We need to be pushing this. We need to be advocating for social prescribing as part of our agenda for helping patients in this model of care. So chronic pain, social prescribing, therapeutic interventions aimed at increasing social connection, hold merit in reducing the impact of pain on engagement with activities. So this is proven. Social prescribing, increased engagement, reduces the impact of pain on that engagement. Being around other people improves your function. Now, so we're moving from the socio to the psycho. So I mentioned originally catastrophization and trauma as key issues to deal with in terms of mood, addiction, and pain. So I view referrals to CBT and mindfulness as crucial in the overall management of chronic pain. And mindfulness is now really beginning to be proven to be effective in stress reduction and having also downstream effects in the management of chronic pain. And there's now good evidence from neurobiology that mindfulness actually shrinks the amygdala, the fear response, the trauma response, and increases the size of the cortex, which allows us to actually rationalize and think and actually manage our pain better. We need to manage the psychological disorders that we see. We need to manage anxiety, depression, and trauma disorders, because unless we do so, our patient is never going to get better. The patient's pain experience is never going to get better. Trauma makes pain. You need to treat trauma. And I'll say it again, we need to identify and address catastrophization. If we don't, our patients will never get better. And in this context of psychological care, I also put in here the need to address addiction issues. AOD counseling, we need to address, if present, comorbid substance use disorders. So we've had the social, now we've got the psychological. And next comes the biological. Physical therapies. So remember, motion is lotion. Active is always better than passive. I tell my patients, do not expect a back rub from a physiotherapist. A good physiotherapist is a sports coach. But physios are not the only people part of a multidisciplinary pain team. So you can have occupational therapists, exercise physiologists, and many, many more. We know, for instance, in terms of movement and biological care, we know that people who practice yoga have got thicker cortices in their brain and are more resilience and less chronic pain. Yoga reduces pain. We also know that exercise at home is crucial to help with lifestyle medicine, to help with central obesity, and therefore, and also stress management and cardiovascular disease risk and self-esteem. And also the downstream benefit of that is ameliorating chronic pain. So how much do people need to exercise? Well, most guidelines say that for everyone needs to be doing at least 150 minutes of moderate exercise a week. What does that mean? So that's half an hour, 5 days a week. Brisk walking is all you need to do. That's enough to keep you going. 75 minutes of vigorous exercise. So if you want to jog, then you can cut your time down by half. The other thing to mention is that sitting is lethal. You need to stand up every 20 minutes. I've just been talking for, I don't know how long I've been talking for, but it's longer than 20 minutes. So notwithstanding the fact that I'm telling you to stand up, I'm sure you're all sitting still, at least I am. But sitting is lethal. So we need to be doing what is known as non-exercise activity. Every 20 minutes, we need to walk, just walking around, make a cup of tea. Standing up for 2 minutes, that every 20 minutes will actually reduce your risk of mortality, will reduce your risk of cardiovascular disease. And again, as part of biological care, I also think about diet. So remember, going back to the lifestyle pillars, diet's so important. So I recommend, first of all, a referral to see a dietitian, but also in general terms, a reduction in saturated and trans fats, increased fiber, and increased whole plants foods. And I suppose as we increase our whole plant consumption and whole grain consumption, I'm also thinking that we should also be reducing our consumption of meat for various reasons, which I won't go into unless I'm asked later on. So there's a biological. And now finally, medical. So how do we manage our patients? Fundamentally, we need to manage the risk of our patients. And it would be lovely to think that all our patients with chronic pain were on doses of opioids that were not consistent with risk. Unfortunately, a large part of our cohort of patients are on high-dose opioids, and we need to manage that. Why do we need to manage that? Well, let's go back to the safety data. As much as people find it challenging, it's really important to emphasize the fact that the reason why we're doing this is because of safety. It's not to improve patients' pain necessarily. It's to improve their safety profile. It's to reduce their risk of dying. Because we know that high-dose opioids, certainly more than 100 of OMED, is more likely to kill you by a factor of 11. And when we're considering tapering opioids, you have to remember that, not only are we reducing the risk of death, but we're reducing the risk of side effects. In particular, cognitive risk, constipation, falls in the elderly, hip fractures. So being on high-dose Targin in the elderly can be a risk factor for hip fracture and then death, rather than respiratory depression and death. But also, it's still important to bear in mind opioid-induced hyperalgesia. So after long-term exposure to high-dose opioids, the brain undergoes various changes which actually increase the experience of pain, or changes the experience of pain in terms of its timing, intensity, quality, and location. So it's more pain all the time. It's worse pain. It changes from a sharp pain to a burning pain, perhaps. And instead of just being in my foot, it's now in my whole leg or in all my back. This is opioid-induced hyperalgesia, and the management of this is opioid reduction. It's not increasing the dose, it's getting them off the opioids. And it's a lot more common than people give credit for. The other thing to mention is that opioid reductions are not typically associated with increased experience of pain. You can get pain flares as you would in any other day. Even when a patient's not undergoing an opioid rotation, they'll experience pain flares. And I personally choose to manage these pain flares with short-acting opioids on top of their long-acting opioid that we're reducing. And I will pause the reduction of patients with severe if they're just not coping. So for instance, during the winter, it's always fraught trying to get someone off opioids during a taper. So I think the spring and the summer are the best times to do it. And I'm happy to pause. But what I don't do is increase the dose of the opioids. So how do we achieve this in practice? So first of all, I think if people are on a number of opioids, it's useful to combine all of the long-acting opioids they're on into one long-acting opioid during doing a rotation. And a rotation in and of itself is a very elegant and quick way of reducing OMED, because if you're rotating from one opioid to another opioid, the dose of the equianalgesic dose of the second opioid has to be reduced because of a lack of cross-tolerance. So for instance, if I'm switching from, say, 200 milligrams of, or 100 milligrams of morphine to 60 milligrams of endone or oxycodone, I actually need to reduce the dose of oxycodone by about half because of a lack of cross-tolerance. So even though the mathematics would tell me that it would be 60 of oxycodone, I'll actually start my patient on 30 of oxycodone. Therefore, I've achieved a dramatic reduction in OMED during that rotation. But having rotated to a long-acting opioid, then the thing is to start gently tapering. And I recommend a starting dose or a starting rate of 10% per week or fortnight. That's not cast in stone. It doesn't really matter how long you do it, so long as patients are reducing, so long as patients are moving towards a position of safety away from a position of risk. For those that can management, I recommend cessation of opioids completely. But for those that can't, I'm happy for the dose of the opioids to stay under OMED 50. If you want more advice on tapering, there's a couple of very useful resources that you can see there. And this is a very good resource. Unfortunately, I can't get this to actually work in my presentation, but the opioid calculator is a fabulous tool which allows you to put in all of the various opioids that patients are using. It then creates the rotation for you and gives you the starting dose of the second opioid that you're actually going to use. And it gives you the profile. So you can actually visually show patients the graph of how you should be reducing your opioids over time. It's a fabulous resource, and it should be used a lot more. And then finally, no man is an island. We need to practice in teams. Where do you go for advice? Now, I've said before that the PBS changes do not require you to refer to a pain specialist. There are other sources of help you can get. So the GP Clinical Advisory Service is available on 1800-812-804, as is the Drug and Alcohol Clinical Advisory Service. And these services are appropriate for people who are experiencing problems in reductions from high opioids. Addiction specialists, Turning Point, and pharmacotherapy area-based GP mentors, they're all available for you. So you don't automatically have to have a trigger referral to a subacute pain clinic. I've said it again. We've got great pain clinics at Eastern Health. We've got the subacute pain clinic and the opioid dependency pain assessment clinic. And I had the privilege of working in the ODPAC clinic with Carlos and the guys. But it's not necessary to refer all of your patients in the community to these services. Remember, just like type 2 diabetes, GPs should own the vast majority of these patients, and they should be able to manage these patients in the community. So let's go back to the case. What did I do? So I stabilized her on 60 twice a day of 60 twice a day of Targin, and I said you can have a maximum 30 milligrams of endo in a day to manage your pain flares. And I gradually weaned her off the Targin, 5 to 10 milligrams every 2 weeks. Over time, we just slowly weaned. And she was very frightened at the beginning. And I said to her, look, if your pain flares get worse, we'll discuss it. We'll talk about it. And she came in and saw me every fortnight. And I kept asking her, is your pain getting worse? Is your pain getting worse? No, it's not. It didn't get worse. She had a couple of pain flares and needed some more endo. But, overall, the pain didn't get worse. And she successfully managed to get to completely off her Targin. But she still uses 5 to 10, 3 times a day of her endone. And remember, when I first met her, she told me it was only the endone that was giving her relief. And it's still only the endone that's giving her relief. And she says to me, and acknowledges openly, that the endone doesn't actually treat any pain. It just makes me high. It makes me feel better. I can cope. And I think that's okay, because at the end of the day, we've just heard at the early part of this talk that chronic non-cancer pain, the tissue healing's done. So whatever's going on is beyond noxious transmission. It's an emotional experience. And if she gets high and gets through the day on 30 of endone, less than OMED 50, I'm okay with that, because I've managed her risk by getting her off the Targin. Endone gets her up in the morning, not because she's in pain, but because she needs a pick-me-up. However, that's not the whole story. She also smokes 20 a day, and she after I managed to get her off the Targin, we started talking about why she didn't feel better, and lo and behold, out comes the truth. 20 cans of double-strength Jim Beam a day, and I gulped. And she doesn't eat, so she's thiamine deficient, because she doesn't eat because alcohol suppresses her appetite. And she's got this chronic bad back with a CT scan that shows nerve root impingement. And as I gradually got to know her as well, we found out that she was a victim of child abuse. She had psychosocial adversity. She was unemployed, living on a DSP pension. She was still living with her separated partner, but they were in separate bedrooms, and she had a son, and it was complicated. She wouldn't all go into it. There were a lot of stressors there. And then one day she just went blind. So we sent her to an ophthalmologist who diagnosed some form of vitamin deficiency causing this toxic amblyopia. We started her on vitamins. She started her on B12 injections, actually. And then I thought, well, is this patient, got all this, is she thiamine deficient? Do we need to give her more thiamine? And then she started getting weakness and numbness in the legs. And remember, she's got a proven disc prolapse. And then she started getting numb in the pelvic area. So then she told me she couldn't feel the brakes on the pedal of the car. Now, bear in mind, this patient's still driving, but she's blind, so I had to actually stop her license. I had to dob her to Vic Roads. But ultimately, I referred her to see a neurosurgeon, who by the way, there's neurosurgery. My original neurosurgery referral was rejected, so I had no other choice but to send this lady into ED. She was seen in ED, and it was felt that there was no surgical target. The cause of her ascending numbness and weakness and pelvic numbness was not a surgical target. So we ratcheted up her oral thiamine, and I had to tell her, look, I'm very concerned about your alcohol. Let's talk about that. So I started her on a camprosate, which is an anti-craving alcohol medication. Did no good. She didn't respond to it at all. Why? Because a camprosate, there are a lot of addiction specialists who feel that a camprosate doesn't work. But B, most importantly, she wasn't engaged in a therapeutic peer support group. So couldn't give her naltrexone, which is the other alcohol anti-craving drug, because she's on endone to get her up in the morning. So I had only one other option, which was baclofen, which is a second-line agent associated with overdose risks. Now, she'd had depression in the past and also previous overdose. So I made her do it, and I made her go to the chemist every day, which she bitterly complained about. Because remember, she now lost her license. She's got partial sightedness. She can't drive a car. She's lost her license. How does she get to the chemist? She lives isolated. But we got over that. And now on 20 TDS, she then was down to 3 cans of Jim Beam a day from a previous 10 to 20 a day. So there was improvement. Then she fell. She fractured her foot, got a clot. And they started her on apixaban. And one of the concerns about baclofen is the risk of duodenal ulcer. This lady's on omeprazole with a previous DU. And now she's on an anticoagulant. And she's still drinking 3 cans of Jim Beam a day. So what do? Excuse me. So I thought long and hard about this, and I rationalized, well, actually, getting her off the alcohol would probably do her more good than anything. So I actually increased the baclofen and told her, look, if you ever start vomiting up blood or you get bellyache, you need to go straight away to ED. At 25, 3 times a day, she was abstinent from alcohol. So that's a big win. This lady's been drinking heavily, 10 to 20 cans for 20 years, and has had a career with alcohol since she was 15. Then I started looking at all the other issues around her life. So particularly the smoking, she was on 20 to 30 a day. And we know that chronic pain and the experience of chronic pain is worsened with smoking. So I said, you have to stop the smokes. She agreed to start Champix. And you have to get more socialized. She's now attending an online AA group. And the next thing I'm working on is getting her to improve her diet. She's a carnivore. During her career, her long career with alcohol, she wasn't eating properly. But when she stopped the drinking, she discovered a real flavor for bacon and steak. And I said, I'm sorry, love, you need to stop that. You need to start getting veggie. And these are the reasons why. Thank you so much for listening. And I really look forward to having an ongoing chat and some questions.
All right, thanks, Ferghal. That was an extraordinary presentation. If anyone has not heard Ferghal before, I do very much recommend attending any of his Meducate lectures or any other online. He's fantastic and sounds like Liam Neeson, which is always really nice to hear.
I have a unique set of skills. I will teach you.
You do. That lady sounds incredibly complex. So I guess my first comment is well done. I mean, she's incredibly complex and obviously you had a fantastic rapport and relationship with her, so it's extraordinary. Christine, I think we've got a question in the chat box. Did you want to just summarise that for Ferghal? She's muted. That's all right. I might read through. I don't know whether you can see this, Ferghal. There's a question from, I'm not sure who the question is from. It looks like it's from Dr. Altaf. Can I ask advice around aged care residents and chronic pain? Accessing psychologists is near impossible. Physio is a hit and miss. Lots of reliance on exercise.
Yeah.
So the question really is, any tips on help with this patient cohort?
Yeah. So look, aged care is fraught with the need to balance what we understand as the best medical principles with the need to manage patients and potentially in a palliative care setting. And one of our colleagues, Dr. Andrew Wang, has always went to great pains to explain to me that, look, when patients reach a certain point in life, palliations is more of a priority than, this idea that we have to stringently reduce opioids is perhaps less pertinent. However, on the other hand, we have to understand that the harms associated with high-dose opioids are perhaps even more impactful in the elderly. The cognitive impact, the impairment, the confusion, the falls risk, the fracture risk, so I can understand how people feel caught between a rock and a hard place. what I do, I'm a great advocate of regular Panadol to begin with. And then if I can get away with it, I use very short courses, less than 7 days of celecoxib, selective COX-2 inhibitors. And then if I have to, then I will go on to Norspan patches if I have to as a third line. So Norspan is buprenorphine via patch. It's less likely to cause respiratory depression. But I am aware that even with Norspan, patients are going to get potentially the side effect risks, which then brings me on to, well, what else can we use for pain management in our elderly patients? So I think, we actually need to think about non-pharmacological management, including things like mindfulness. Just because you're old doesn't mean you don't benefit from meditation. Just because you're old doesn't mean you won't benefit from exercise. You can do exercise in a chair and you can socialize. Again, it goes back to the lifestyle pillars. Get them socializing, get them moving, get them heat packs, get them physio. Anything that you can do to improve the experience of someone in a nursing home will actually downstream improve that patient's experience of pain. Treat their depression. Depression, the holy trinity of human misery is depression, addiction, and chronic pain. Get the depression treated. Get the catastrophizing treated. So when we're doing ward rounds in nursing homes, it's really easy to think about the pharmacological solution, but actually we should be thinking about everything else. We should be thinking about the lifestyle pillars before we even think about the prescription pad. And I don't have anything else to say. It's really complicated. I think that's why GPs are having a tough time at the moment, because we're being expected to manage so much risk. And I always say to people, anyone who will listen, general practice is the easiest job to do badly, but it's the hardest job to do well.
Yeah, couldn't agree more. Yeah, couldn't agree more. So we've just got Michelle's put in a comment, the pain in residential aged care facilities management strategies is available and a good resource. Any other questions? Anyone's happy to put their hands up. You may have, I'm sure we've all got patients perhaps we might need some advice on. You're welcome to pop it in the chat box. You're welcome to put your hand up and speak. I know we've got some members of our pain team if they want to share any wisdoms.
So I think there's one nice comment here from Sue Yenkin talking about the MS Society that have volunteers who they match with clients. They can visit or phone patients to provide that social support. So I think that that's very pertinent to the importance of that alleviating social isolation and rapport.
I guess sorry, you go, Ferg.
So, Christine, you just triggered something in my memory. Diet is actually, there's emerging evidence that saturated fats will actually worsen MS, and people who are on a low saturated fat diet, they tend not to be the ones that progress. Now, again, all these nutritional and dietetic studies have never been randomized control trials, so there's no direct there's no direct causation, but there are association studies which suggest there is a link between saturated fats and MS. So again, going back to the pillars of lifestyle medicine, diet is a key element in managing this.
I had thought that this might be a COVID-free chat, but I guess I'm wondering with COVID, living and breathing it, but that increase of loneliness, obviously, that we're seeing, in addition to people perhaps not being able to do their regular activities, has anyone noticed an increase in an issue? So Sue Yankin's got her hand up.
Yeah, I certainly do. Like, I work at Eastern Health. I also work for Cabrini with chronic diseases, and I guess I have to say that we have an online pain management program at Eastern Health, and the participants that have come, in this COVID world have said how wonderful it's been, even virtually, to be able to connect. And it makes a really big difference. And even when they were face-to-face, when I asked participants what was the best part of the program at Eastern Health Pain Management, they talked about being amongst kindred spirits, people who understood their pain. And I think one of the most amazing things we've done at Eastern Health is to develop a number of pain management support groups that continue on, that we continue to support, and we put under different sort of organisations like APMA, so that these support groups continue in a professional way. We've got facilitators who are people who've done the program, who live with pain, And we continue to really encourage, and we have one of our topics in the pain management program is social isolation and social connection. So we really, really work with that sort of stuff.
Yeah. So one of the questions in the chat room was to clarify what does BPD mean. So BPD in this context means borderline personality disorder. It's not the same as BAD, which is bipolar affective disorder. So BPD we know is a trauma response, and as part of the trauma diagnosis, it increases the experience of pain or reduce resilience, reduce emotional resilience, which then reduces the ability to deal with pain. And it needs to be identified. It needs to be managed appropriately. And one of the questions also was, what do you do when Norsplan doesn't work? I think it's really important to understand that there are going to be non-opioid responsive pains. And we're dealing with a cohort of patients that have potentially, all of them potentially have non-opioid responsive pain. And why do I say that? Well, from a teleological point of view, we're reducing their opioids and their pain's not getting worse. That's point number one. Point number two, we know that opioids don't work for chronic non-cancer pain. That space after 3 months, that space where angels fear to tread is not opioid responsive. And it can only respond to the socio-psycho-biomedical model of care, which involves all of the other aspects of care other than the Norsplan. So I really want people to understand, in this context, the prescription pad is not your friend. And looking for a solution via the prescription pad is just not going to work. You need to think more broadly. And how do we think more broadly? How do we contemplate this problem? Well, the 6 pillars of lifestyle medicine is just one way of thinking about all of the potential and all of the possible interventions that are available that you can possibly use to help the patient in front of you.
I think there was a couple more questions in the chat box. Christine, have you had a chance to look at them? I must admit, there's the last one I haven't.
Yes, there's one question about managing patients with chronic osteoarthritis who are awaiting joint replacement, especially now that the waiting periods are longer.
Yeah. So look. Again, is this acute on chronic pain or is this chronic pain? If you have to use opioids, look, we know that opioids beyond OMED 50 start to increase the risks. We know that opioids beyond an OMED of 100 definitely increases the risk of death. Keep them underneath an OMED of 50. That's, I think, the most recent guidance from the great and the good organizations. And there was also a question about isn't changing someone from long-acting regular opioids to short-acting regular opioids creating a more addictive issue? Right, that's a really interesting point. So that space wherein angels fear to tread is full of opioid-induced hyperalgesia. You have to get them off their long-acting opioids. And look, I appreciate that I'm not perhaps mainstream in my thinking here, but the way I think about this is that pain flares in chronic pain is an acute emotional response. And if they get high, they get high. You've got to, so long as you are reducing their overall risk by reducing their background opioid load, they can still have that, they can still use the short-acting opioids, so long as you keep them under an OMED of 50. Now, okay, so people might say, my use of the word high is inappropriate or it creates addiction responses. If I'd said their expression of chronic pain, they were expressing a pain flare that only the endone worked for, well, that might make people feel better. But I am aware that the current golden advice, best practice advice, is to convert all of the opioids, including the short-acting opioids, into one long-acting opioid and then taper that. To my mind, that doesn't give the patient any room to maneuver to manage the pain flare. But I'd be interested in what other people think about this.
Any other questions for Ferghal or the pain team while we're here? Feedback. Any members of the pain team, if they've got any comments? Carlos, as team leader, did you want to talk about the pain service or?
I think Eddie's got a comment actually.
Okay, there you go. That was good timing.
Yeah, as the physio in the pain, one of the physios in the pain team, I have never heard a doctor talk about physio and the role of physio in chronic pain so well, Ferghal. it was really wonderful to hear the role of exercise as a general therapy and the change it can make physiologically aside from just the pain area and working biomechanically. So it was just great to hear that general exercise has a role in reducing pain, not just specific exercises for that particular area of pain.
Yeah, it's so true.
Sorry, Michelle, you go.
Do you mind if I just for 2 seconds, just to Kay, just in response to your question about specifically residential aged care, I've put a link in the chat for you to the actual management guidelines if you're interested in having a look. They've got some really good practical resources. My apologies, my daughter won't go to bed. It's got some really good practical strategies, and it was written by a number of different pain doctors. There are some psychologists, occupational therapists, physiotherapists, all involved in that. So it's a really good resource. Highly encourage anyone that works in residential aged care, make sure your facility has a copy of that.
Fantastic. And Christine, from a PHN perspective, I know a lot of you probably know the PHN has done a lot of work in this space. Did you want to comment on supports the PHN perhaps can offer to GPs?
Yes.
Sorry, question without notice.
Yeah, it is. I guess it's, we do have that connection with the pharmacotherapy area-based networks and the work that the liaison officers do there to help people who need to start people on opioid replacement therapy. There's those connections, and there's always lots of events on our website of interest in the pain space. I think at the moment everybody's concerned about COVID, but that brings up some very I think salient issues, particularly around social isolation and the greater difficulty, and that it's so important to have that perspective of the patient, that human empathy that Ferghal started off with in this space, because people won't get better with judgments alone. So I think there's a lot. I think Ferghal has really nailed a lot of the issues tonight.
Yeah.
Christine, can I just say something about ORT? There's one of the things that really concerns me is the idea that methadone is safe, and that the idea that someone can be converted from high-dose oral morphine equivalent drugs, other opioids, to methadone. And because methadone is regarded as safe in the context of heroin use disorder, they think it's safe in the context of prescription opioid use disorder. And so people would say to me, oh, it's okay now, I've got him on methadone. And my heart shudders when I hear that phrase. Methadone is really dangerous, especially in the context of prescription opioid use disorder. And the safety of any methadone program lies not in the methadone, but in the program. And unfortunately, people who are using methadone to manage chronic pain, they don't have a program. They don't do the daily pickups, the regular reviews, the urine tests. They don't do that. And so people die. So I don't ever recommend methadone for prescription opioid use disorder. I recommend buprenorphine. So either Norspam patches or Suboxone if you have to diagnose prescription opioid use disorder, and then potentially ongoing use of long-acting injectable buprenorphines such as Buvidal or Sublocade. So yeah, just to emphasize, methadone is not the be-all and end-all of prescription opioid use disorder. It doesn't in any way mitigate the risk, in my opinion.
Fantastic.
There's a question here as well. There are some concerns with Schedule 8 reviews being done by colleagues. Is this what GPs feel? So I'm presuming you're talking about the PBS review, this 12-month review. It specifically states it does not have to be a pain specialist. It can be a GP in your practice. This is one of the key messages that I wanted to get across tonight for GPs watching at home. That anyone in your practice can actually do this review. And it's an opportunity to assess the diagnosis, the original indication for the chronic pain, to assess the risks, to identify the risks, look at SafeScript, find out where they're at, and then put in place mechanisms and sometimes rotations and tapering to actually mitigate that risk. And sometimes a second opinion is enough to actually say to a patient, look, we need to look at this more. Because when you're very closely enmeshed or involved in a patient care, and you're the one that's actually escalating the opioids, it can be quite difficult to have to de-escalate them. And this 12-month review should be seen as an opportunity for a second opinion to say, well, hang on, your pain's still bad, your opioids haven't worked, let's try a different pathway. And I've never seen a patient on high-dose opioids who said to me, you know what, doc, these opioids are fabulous. My chronic pain's really well controlled. I can go out, I can joke, I can laugh, I can play football, I can take my son or daughter to the park because I'm on 900 of morphine a day. I've never seen that patient. The patients that I see are, despite my 900 of morphine, I can barely get out of bed and make breakfast for my grandkid. So opioids don't work for chronic pain.
Fantastic. I think that's a really great note to finish on. I'm very minded that it's after 7:30, but on behalf of us all in different locations, I'd very much like to thank Dr. Ferghal Armstrong. So we can all give him a clap, a virtual wave or something. Well done. That was fantastic, Ferghal. Very practical. Yeah, lots of claps. That's fantastic. Daresh has even put a little hand clap. That's very clever. I really like that. Oh, yeah, Eddie's done it too. And also to thanks to Carlos and the pain team. Oh, I didn't know you could do that. That's exciting. As I said, we will send you a feedback form. If you don't get your certificate, just email Carlos to receive that. But I am sure that we will ask Ferghal to present some more because he's such a brilliant presenter. So thank you so much, and thank you for sharing your Wednesday evening with us. And stay well.
Thank you. I've enjoyed it. Thank you.
All right, everyone. Stay well.
Bye.